So Timbuktu, Ghana, Mali, Sumanguru, you know what you're shown. What you're shown.
Enjoy some fabulous rewards. Get a cool £10 reward when you receive £100 or more from the UK. Tell your friends and family in the UK to send money to your mobile money wallet or bank account using Express Pay and get an extra £10. Terms and conditions apply.
Good evening, ladies and gentlemen, and welcome to the 8th edition of the Ghanaian Community Awareness Forum. My name is Emmanuel Kwasin, the chairman of Ghana Union, and tonight we have an interesting topic which I'm sure by the time we all leave here, we will be more than happy to have been part of today's program. Tonight we will have panelists who are being on the field in the area we are about to talk about, and they are here to give us all the knowledge, all the ideas, all the expertise that we so need so much. In doing so, let me just introduce ourselves to this program. This program is put together by kind support and cooperation from a number of organizations: the Ghana Nurses Association UK, the Western Region Association UK, Western Region Nurses Association UK, the Nightingale Ghanaian Nurses Association UK, and of course with Ghana Union. It is a program supported by Express Pay, money transfer, your money in the right place, and the cool part of it is that you get £10. Whoever received the money in Ghana get £10 when they send. They are here to support us to be able to bring you this program, to be able to cover any other aspect of cost. And so we ask you to patronize their services. The program is also in partnership and with support from the Ghana High Commission, giving us the endorsement to run this on behalf of the community and also make sure we can give the information to you all. Omega Live TV is also part of the partnership, and we are grateful for their support. And this program is being televised live on Facebook, YouTube, and on other social media channels, including the Zoom that you're on now. At this point, let me just spell out a few rules as always. As a program, we want to make sure we follow some standard order. So all audience will be muted throughout the program, except host and the panelists who can unmute themselves for Q&A. Where possible, we ask that please kindly show your face when you are asking a question, and please go straight to the point so that we can give room for others to obviously interact. If you have any questions to raise in the course of the program, please use the Zoom icon and put your chat there, or raise your hand so that when we can get to you and to be able to ask your questions. There will be no right of access for any audience on this program to share screen, and so please do not attempt to do so. We are hoping that by the time you leave here tonight, you'll be well equipped and well informed to make the right choices that meet your health needs and for the good of the community. On that note, I'm going to introduce to you Dr. Paul Mensah. Dr. Paul Mensah is a consultant obstetrician and gynecologist with the NHS Scotland, who will take in turn and take us through the remaining experts on schedule today to give us their presentations. Dr. Mensah, please take over.
Well, thank you very much, Emmanuel, and also thank you for all those who have joined us. As the title of our program states, we're looking at obstacles and some of the challenges to women's health, gynecological health in the UK and also in Ghana. And I must admit that we have a very high-powered panelists who have international experience and therefore will cover the subject in a greater detail. And I'm sure everybody will be fine with that. And because it's to do with women's health, I think it's just reasonable that we start off with a lady doing the first presentation. So it's my pleasure to give you a bit of a background about Dr. Theodore Pepra. Dr. Pepra was born in Ghana. She attended the Achimota School before she continued her education here in the United Kingdom. She finished from the qualified in the University of London, and then she took higher training, mainly in teaching hospitals in London, that included St. Mary's Hospital, the Royal Free Hospital, the Hammersmith Hospital, and St. George's Hospital. So she's been around. In 2009, she was appointed consultant gynecologist at Guy's and St. Thomas's in London. And then in 2011, was elected a fellow of the Royal College of Obstetricians and Gynecologists. In 2013, she stepped down from her full-time NHS employment and took up a part-time consultant position at St. George's Hospital, London. And this major shift in her career was to allow her to get involved in teaching in volunteer programs in Ghana, particularly, and I need to emphasize that, particularly in the field of cervical cancer prevention and then women's ultrasound and maternal life-saving skills. And she's an accredited member and a trainer of the British Society of Colposcopy and Cervical Pathology, being involved in developing colposcopy training courses for Ghanaian doctors and nurses. And I know she works very closely with the team at the hospital, Roman Catholic Hospital in Bato, with Dr. Kofi Efa, because I've seen some of your work with Dr. Efa. Also has a diploma from the Royal College Faculty of Sexual and Reproductive Health. So since 2019, she's been based in Ghana, but she continues to be involved in lecturing and training in various aspects of women's health on the international stage. And this is one such stage. So Dr. Pepra is going to take us through women's gynecological cancer, some of the obstacles and challenges to accessing good quality care for those in our community. So Dr. Pepra, I'll hand over to you now.
Thank you very much for that introduction. I appreciate it. And thank you very much for asking me to speak on this very widespread audience. I'm just going to share my screen and then we will get going. So, as I say, we are going to just discuss some of the obstacles, and my talk is particularly about the early diagnosis of gynecological cancers, a lot of which are actually preventable. So there are barriers. There are different barriers for different women. And I think sometimes we need to be careful about grouping everybody together, because maybe this is why we're sometimes not reaching the right people, because there are different barriers relating to African women, different barriers relating to Caribbean women. We're often grouped together as Black women, but actually we're quite different. And even if you look at the white women, Eastern European women may have different barriers. And even within the UK, somebody in the north of England, actually there are different barriers and ways to approach those women from women in the south of England. But there are certainly common barriers for all women. And I think that's what we'll touch on, and I will also then elaborate more on, I think, barriers that particularly influence Ghanaian women. Before I go into more of the barriers, I just want to take this opportunity to just spend 5 minutes talking about women's cancer prevention for the platform. I believe we have quite a few lay people joining in. I'll just touch on breast cancer prevention. Self-examination is the best thing to do. Get to know your own breasts, and then you will know very quickly if there's a problem, even before the mammogram. And this is something all women can do, and you can actually get a lot of information on the internet as to how to do this, or ask your healthcare professional. As Dr. Minster said, cervical cancer is my biggest area of interest, particularly because it's one of our biggest killers in sub-Saharan Africa. And yet we actually are a bit behind in prevention of what is a very preventable cancer. So prevention is either the primary prevention in terms of vaccination, and also then secondary prevention is that in terms of pap smear, and then treatment. Once you have symptoms of discharge and so on, now we are then looking for cancer, whereas we want to screen people before they even reach that stage. And that's a really important distinction, because some clinics that I've been to in Ghana, they said, oh yes, we have a screening clinic. Women come when they have a discharge. I said, no, when some have a discharge, we've missed the boat. So it's how to get them in at that prevention stage. Womb cancer as well. Women with irregular, prolonged bleeding, please don't sit at home, worry about it. Please seek help, doctor for examination. And then ovarian cancer, which is the silent killer. The symptoms are very vague, but I think if you have any of these symptoms, report them to your healthcare professional, because they may be able to join the dots and put it all together. Vague symptoms, feeling full, quickly loss of appetite. Sometimes you feel you're losing weight, but your waist is still growing, and that's puzzling. All these are vague symptoms, but don't hold back from coming forward. We want to hear what your problems are. So coming back on topic, so common barriers for all women. Now let's assume the obstacles of accessibility, availability, and affordability have been taken care of. Now I'm saying that because in the UK, that to a large degree is the case. We try and make the clinics as accessible as possible, although there's still work to be done there, try and make them as available as possible. And certainly affordability is not really an issue, except for maybe somebody's transport to and from the facility. And even then, the NHS has ways of taking care of that. So these are aspects that Ghanaian women in the UK will not have so much of a challenge with, but they certainly will be three big asks that we have in Ghana. And having the opportunity of having sampled both types of service, I can certainly appreciate that these are certainly not assumed in Ghana. So the common barriers for all, and that's for all women, regardless of their race. And therefore, a number of these will certainly be the barriers for Ghanaian women, but I will focus in a bit later on what I think the barriers for Ghanaian women are. Fear of vaginal examination is always something. And even to have a pap smear, some people have said, I'm afraid the results will be abnormal. And I said, well, if it's abnormal, then we can do something about it. And they said, no, it's not my portion, doctor. I'm not going to, I don't even want to do the test because that will encourage a bad result. I don't quite know how to convince them over that. We do have, I've highlighted cultural and religious reasons why we don't want to go for testing or for vaccination. Sometimes it's a concern about what are they going to put in the vaccine. The other thing is that at a screening level, we're actually not particularly ill. So we think if you're not ill, why go and get a vaccine or why go and see the doctor? Because they may even do something to make you ill. Sometimes you go along and then we actually find a problem. The problem was there. It's not the doctor or the nurse that put it there. Privacy. Now, privacy, I think, is more of an issue, I think, in Ghana, because people are concerned about their business being talked about. The lab technician, it's a very small place in Ghana. The lab technician might know your relative. And we struggle with this idea in Ghana of confidentiality being not to the family, and rather it's just for the person. So it's a constant thing that we're doing, training staff in Ghana, that confidentiality is to the person and not to the whole family. And, there's certain stories of people finding that their doctor or nurse is talking about their health issues in the bar on a Friday night. That is far less of a problem, I believe, in the UK. Perhaps my colleagues who are still there might correct me. I think that's far less of a problem. The other common barrier is that people are worried, this is gynecology, they're worried about being asked questions about their lifestyle. I do warn people at the beginning of consultations that I will be asking personal questions for valid reasons, not just out of curiosity. And I just set the stage there because we do have to ask intimate details. Again, common barriers, I'm too busy to go. Too busy and too busy with the kids, too busy with my job. And then there's actually sometimes no encouragement. Men are really a part of this, and there are a number of studies, particularly showing the influence of a man's opinion for the woman in Ghana as to whether she goes for even her screening or not. And sometimes they have vested interest in perhaps a woman not going for screening. And that's partly because it's our own fault. We sometimes stigmatize women who have an abnormal pap smear, and we actually sometimes put out the wrong message. There are healthcare professionals in Ghana who will say that you only have to go for a pap smear if you're promiscuous. I mean, that's actually true. I've heard it with my own ears, and that's really disappointing. But these are some of the things where I say we have poor counseling, how the information is conveyed, and relevant imagery, and stigmatization is a really big problem. And certainly people may have a negative past experience. And again, so low perceived risk of cervical cancer. I am touching on cervical cancer because it's one of those that you have no symptoms in the pre-cancer stage. So somebody feels well, and then I keep hearing this, it's not my portion. So I said, well, whose portion is it then? I mean, we are all church goers to a large degree of various denominations and religions, and whose portion is it? There is also the very real issue of historical issues of unethical healthcare research. That's a real thing that has happened. And I think we actually need to acknowledge that rather than just dismiss it, because it has happened and we need to acknowledge it, discuss it, and then take people beyond that. Then we probably have some kind of lack of communication. It must be between from the trusted providers and community leaders. So if the message isn't going out from doctors or nurses or not being accepted, who we have to identify, who do people trust, and try and work with them. Now we are all connected, Ghana, UK. I mean, so if you have basically what I'm trying to say is that because a Ghanaian woman is in the UK, she's still very Ghanaian. And I think that's a good thing. You can take a lady out of Ghana, but you don't take Ghana out of the lady. We are always still there. And we the women in Ghana will be communicating, either they would have lived in Ghana or they're certainly in touch with relatives here. And therefore, I really feel that issues in Ghana really translate into some of the issues that create obstacles. So, and the obstacles are not because the facilities are barring them, it's our own prejudices and concerns and mistrust and so on that lead these. I think I did speak to a number of colleagues in the UK, particularly in the area of cervical cancer prevention and oncology, and as well as some of my friends and acquaintances who may be from the diaspora or still there. And certainly religion was top of the list as to why people are not accessing the healthcare that's provided for them in the UK and even here. Just this evening, I heard a story. Someone said that she was supposed to come for an MRI, but she needed clearance from her pastor before she could come. These are some of the obstacles, very real obstacles we're dealing with, and we have to think about creative ways of getting past that. I've talked about the mistrust, privacy issue, the fear of questions and lifestyle. So these are things I've touched on already, but these are the things I think are highlighted areas for women of Ghanaian origin. touching back on the cervical cancer thing, which is a good example. So we have primary prevention from the HPV vaccination, secondary prevention from screening. And really the primary prevention, for example, in the UK, they started vaccinating young girls back in 2008. And studies done 10 years later show very, very clearly that it works. I mean, I don't think there's anyone who really is doubting. The evidence is clear. Nearly 90% reduction in women who've been vaccinated from a risk of cervical cancer. That's huge. And here we are in Ghana with it being one of our leading cancer killers. So again, these are some of the areas we've touched on in terms of vaccination. There's some valid cultural and religious things. Does it have animal products in, which may not, maybe some of them have, pig products or whatever. The stigmatization, and these are even questions that were asked when it was first rolled out in 2008. Is the vaccine going to make my daughter promiscuous? We have work to do to convince people of the right things to do and to get over some of these problems. We have to counsel them properly to take away that surprise and anxiety, the guilt, the shame, and we healthcare professionals need to give accurate information. If we're not giving accurate information, they're just going to go onto Google or to, I would say, unscrupulous herbalists, because there are, very credible herbalists out there. And they'll be getting the wrong information. And there's lots of places on the internet they can get the wrong information. So the barriers to uptake must be understood and addressed. So we healthcare professionals have work to do. We need to educate ourselves better. We need to improve counseling, make it relevant, appropriate, and truthful, empathic, destigmatize the female issues and be non-judgmental. And we have to engage with and educate the opinion leaders. These are suggestions that I'm making. I think, there's work to be done. Then the other key thing with cervical cancer prevention is that we need to look at offering self-sampling so that women can do their own pap smears and then send it in. So as I say, mistrust needs to be acknowledged and addressed, because I think the minority ethnic groups, historically, we've been underrepresented within health care research. So I just think we need to get that imagery out there a bit more, showing that we do, some of us are in there. I mean, even with the recent COVID vaccine trials, and I said, we do have a number of Black scientists involved in these trials, so we don't need to be as fearful as perhaps 100 years ago. But definitely, wrong things were done to Black people in trials, and even a very famous gynecologist, so Sims used African women to test out his speculum. Wrong things have been done, but we need to get past that. Imagery showing, I think certainly in Ghana, they're now promoting showing a lot of women in those aspects to encourage women who are nervous about coming to a clinic to see a man, which sometimes they are. Then also engaging community champions. This is a picture from a cervical cancer call to action in January last year in Ghana. And, the women in this thing, I know some of the audience may recognize some of them, but they apparently were TV presenters and actresses and so on, who came on board as cervical cancer champions to an event that was launched by the second lady. So this is just the imagery of getting women out there. And when I say we need to engage with the community. Now that isn't necessary, that could just be even, who do people listen to? Hairdressers are like, people actually go and tell their stories to hairdressers, especially when you're sitting there for 5 hours having your hair plaited. Or longer. So it's actually trying to find out who are the opinion leaders, because it's not us, clearly, or we're not doing enough of a job to be recognized. Who are the opinion leaders? Let's get down and try and engage with them. There's a program on TV called Pastors' Wives. We actually need to see how we can engage with these various people, because they actually are more trusted in Ghana than healthcare professionals to a certain degree. They put their adverts up, and people actually, it costs more to have a consultation with a pastor than a doctor. You know, some pastors are charging 500 or 600 CDs, and then they sell you the simple bottle of water, which has been blessed, that costs about 2 CDs. They sell it to you for 20 CDs. And they actually reach a wider audience. So it's certainly something that we have to just live with. And, you know, there's all kinds of, apologize, this slide is a bit blurred, but there's all kinds of fake news out there, and then they'll tell you drink a potion. One potion cures diabetes, cancer, sexual weakness, fertility, just the one thing. We certainly have work to do, but we can engage through primary and community care. You know, focus groups, and, you know, maybe even some of the audience, you know, we maybe following on from this, there's a focus group panel. What do women want to hear? What would make them come and see us? What are the obstacles? Because, you know, there's various research out there, but at the end of the day, women are intelligent and we need to find out what they want. The imagery maybe we're putting out is not relevant to them, or maybe they find some of it condescending. And then, you know, I'm going to put it out there. We run training sessions for the faith leaders, because I think the faith leaders have the biggest audience, certainly in Ghana, and I'm sure that translates to Ghanaians in the UK. So we just have to find a way of getting them on board. And certainly if we have any of them who themselves have gone through some screening or whatever, because even in Ghana, if the pastor or his wife gets up and says, the whole congregation should go for screening, they'll all go. But that's patchy. We want something more comprehensive that's part of a whole community engagement to happen. So at the end of the day, I mean, we can just, you know, there's the fear. Well, a lot of these things are underpinned by fear and mistrust. So fear, we can forget everything and run, or we face everything and rise. And I think this is what we have to do, because we're kind of in the dark at the moment, trying to gauge what we should be doing. But I think we need to try and come out of that. We've only really scratched the tip of the surface as to why women aren't coming forward. And we need to try and take everybody on the journey with us to some kind of success, because the healthcare is there, and the obstacles are within us in terms of not accessing them, by and large. Thank you.
Well, thank you so very much, Dr. Pepra, for the insight you provided. And I'm sure a lot of what you've said is likely to generate a few questions that come through. And I certainly already have a question for you. So be on the lookout for that. So thank you so very much for covering that aspect of women's health and the barriers to accessing the healthcare. So what we're going to do is now move on, and we're going to be calling shortly on Dr. Paul Fiajo. Dr. Fiajo completed his basic training at University of Ghana Medical School in Kolebu, and then followed up in the United Kingdom, in Ops and Ghana in the UK, and then specialized in pelvic floor problems. He also completed a 12-month fellowship in pelvic floor problems in Australia. And that's why I said at the beginning that the panelists are all so very international and therefore come with a lot of experience. So currently, he's the lead urogynecologist at the Mid and South Essex University Hospitals Foundation Trust. And interestingly, he has taken charity work in Nepal, India, Zambia, and in Ghana. So you get the idea of this wide experience across the globe. He helped to set up the keyhole surgical training in Zambia through the Out of Africa charity, and also help with the Urogynecology Fellowship Program in Ghana through the Ghana College of Physicians and Surgeons, and also the International Urogynecology Association. So this internal outreach, as I've said, means that he comes with a wealth of experience in dealing with different groups of women. So in layman's language, waterworks problems. Paul Fiajo.
Thank you very much, Paul Manson, for And also thanks to the team for giving me the opportunity to share my knowledge on this area, an area that I'm really passionate about, and think that we need to get our women to know more about this so that they don't have to suffer. The team is going to be in charge of my slides, and they will be put them on as we go along. So the next slide, it's, what do we mean by urinary incontinence? And basically, urinary incontinence means that it's an involuntary loss of urine. So you are not expecting this urine to come out, and then suddenly it pops out. And so that's what we mean by urinary incontinence. Next slide, please. And why do we have to talk about urinary incontinence? And this is because about a third of women are affected by this condition. A third of women are affected by this condition. And there is the assumption that aging, urinary incontinence is just part of one of those things. As you get older, you leak urine. And so a lot of women then accept that as that process. But also, I would want people to understand that actually it's not just aging, but there's all the age groups do suffer, from urinary incontinence, from children all the way to the older age group. And it's still important to talk about it because actually these things, even though, they are not cancer, it does affect, people significantly with an impact on the quality of life. And a lot of the time people are not aware that actually there are treatment for these conditions and they don't need to suffer. So it's quite critical that, something that is affecting this large group of people needs to be talked about. Next slide, please. So what does the bat think about this? So we've got two bats there, an older one and a young one. So the older bat, asks the question, do you know what I fear most about old age? And the young one said, no, what? And then the older one said, incontinence. Now, bats, as you can see, hanging from a tree, you can imagine if you're having urinary incontinence or if you're even unlucky to having, fecal incontinence, these things are going to come down your face, and hence you're not going to put up with it. And the reason why we end up putting up this kind of incontinence is because we are on 2 feet. We can wear black clothes and hide our leakage. And hence, it's still important that, we take this information from the bats that look, something's got to be done about it. Next slide, please. Why does women have urinary incontinence? The first thing is pregnancy. So, the bare fact that you are pregnant is enough to cause you a problem because the pregnancy does put pressure on your pelvic floor. Next is labor. The longer your labor, the first stage of labor or the second stage of labor, the higher your chances. And the form of delivery becomes important, whether it's a normal delivery, what we call a suction delivery, or a forceps delivery, significantly increase your chances of developing urinary incontinence in the future. Menopause is the next thing, and it's in twofold. The fact that you lack estrogen at this point means that your collagen tissues get weaker, but also some of those injuries that have happened during your pregnancy, and then your childbirth become much magnified or made worse by this lack of estrogen or female hormones. And so menopause is a big thing. Chronic cough, constipation, heavy lifting are all things that increase your intra-abdominal pressure and therefore put pressure on your pelvic floor. And then we've got people who, we've talked about collagen, who have got congenitally weak collagen, that's how they've been born, and therefore develop problems like this. But when you look at all these various factors, the single most important risk factor or reason why this happened is the age at which women are having their first baby. Like we said, all the damage is done by the first baby. Don't blame the second one, don't blame the third one, the first one. And that age is ideally you should have your first baby before the age of 25. I know that has completely destroyed most of my medical students because by the time, they finish medical school and then start thinking of having babies, they're way past, the age of 30. But also overall, you can understand why this become a big issue, because most women, are having children much later on because, yes, they've got to deal with their careers, or excel in their various areas. But whilst we talk about the fact that the age of first delivery is important, you never know. It may be that you'll be designed to have babies, and so you can have your first one at 40 and you still be fine. But majority of the women would not survive that. Next slide, please. So what's the reality here? The reality, if you look at this slide, is on the left-hand side is what the normal vagina, in the middle of the screen, is what the normal vagina should be like. But suddenly this baby, you can see the baby head stretching the vagina. So the vagina has to stretch about 10 times its size, spit out this monster. And then we expect that, in 6 weeks, 12 weeks time, the vagina should shrink back, to its normal size, hold your bowel, hold your bladder, and reduce its size enough to keep the man happy. Unfortunately, that is not reality, and hence why we've got these issues. Next slide, please. So now what are the types of urinary incontinence? We've got what we call stress urinary incontinence, urge incontinence, and continuous incontinence, which is usually related to fistula. For today's talk, we're going to pack our incontinence related to fistula, and that's for another day, and concentrate basically on stress incontinence and urge incontinence, which is affecting quite a large population, and most people are living with that. Next slide, please. So what is stress incontinence? This is basically a urine leakage that is associated with either coughing, sneezing, laughing, exercising. And also stress incontinence is the one that is associated with leakage at penetration, at the time of penetration. So that's what stress incontinence is about. Next slide, please. Then the next thing is about urge incontinence. And urge incontinence, that's the kind of symptoms or things people will talk about is that out of the blue, you suddenly have an urge to pass urine. So you've been completely fine. Not that you were thinking, I need to pee soon, or I need to pass urine very soon, and you keep deferring it, and then suddenly you have to go. No. In this scenario for urge urinary incontinence, out of the blue, you suddenly feel like you need to go, and you cannot postpone it. And a next group of people will then, by the time they can get to the loo, they start leaking before getting there. People wake up in the night to pass urine. We know that people can get up once or twice, pass urine, and their quality of sleep is not bothered. But our view is that really, if a woman gets up once and her quality of sleep is disturbed, that is not acceptable. It may be that somebody else will do it twice and they're still fine, but it's the quality of your sleep being affected. And then a lot of these women with urge incontinence, they can tell you that when I get to town, I know every single spot where the toilets are. And that is because they need to know so that when they get that symptoms of that sudden rush to go, they can find that loo quite quickly and not embarrass themselves. And then you go and do your shopping, you come back, you're putting the key in the door, and then suddenly you need to go. And you sometimes have to leave the things at the door and rush into your loo. That's what we call the latch and key syndrome. And then coming back to intercourse again, the form of leakage you get at orgasm, because women can leak a lot of urine at the time of orgasm, that is related to urge urinary incontinence. Remember, I said the one that is related to penetration is stress incontinence. Next slide, please. So, urinary incontinence, the picture on your left-hand side is a typical urge incontinence patient. Suddenly, she needs to go. She cannot wait in the queue. She's jumping the queue, rushing, break the door down, and try and get in the loo before she gets, embarrassed. Or in a stress incontinence, you're probably going to have to end up crossing your leg when you're doing that coughing, sneezing, or laughing. And everybody's thinking, why does she always cross her leg, when she's laughing or when she's coughing? Because obviously there's something you want to hide. And also it's quite critical that, some of these things happen and you don't want to do anything about it until suddenly, your grandchild or your little daughter or little boy tells you, grandma, you smell, or, ma, I think you smell with urine. And then suddenly that's something that pushes people to say, no, I've got to have to do something about this because this is not right. Next slide, please. So what can we do about it? This is where it's important to take notes and know that there are things that you can do about this. Next, please. Next slide, please. So in terms of stress urinary incontinence, the general things that you can do is you got to deal with those underlying factors that we say can be associated with incontinence. And you remember we mentioned stuff about, chronic cough. Go see the doctor, let them find out what's the cause of it. Let them treat you and so that you can stop having this terrible cough. Because sometimes, even if you go and have treatment and the underlying problem of coughing is not resolved, you're just going to end up with more problems because you destroy whatever they've done to try and to help you with that. If you're doing heavy lifting, please, cut back on that. So chronic constipation, get your bowel improved so that you can minimize damages to your pelvic floor. Those that are overweight, yes, weight puts a lot of pressure on your pelvic floor, and just losing weight, you'll be surprised how much of that leakage that you're getting as part of your stress incontinence, that gets better. So losing weight is quite important. Pelvic floor muscle exercise, everybody says, most women that I will see will say, look, once when I had my babies, oh yes, they showed us how to do this exercise, but I just forgot about doing them. I don't do them anymore. Once you've had babies, pelvic floor exercise is for life. It becomes your lifestyle. So as much as as frequent as you can remember, please try and do them because that will save you a lot of trouble in the future. And then those that smoke, smoking is associated with stress incontinence because obviously, the irritations and the cough that comes with that. Next slide, please. And obviously, once the general things have been dealt with, we kind of start talking about, okay, what are the things that, all the doctors can do to help? And periurethral bulking basically means, there are special gels that we can inject into the pipeline to try and narrow the urethral pipeline or the pipeline so that when you then cough, obviously, there's a little bit more obstruction to the urine so it doesn't just, spat out. So that's periurethral bulking. And you can have it once, you can have it twice. Sometimes if it's not working well the first time, it can be topped up and then to try and improve that. And then we can also use the covering of your six-pack, or what we call the rectus sheath, of the around the tummy, we can use those tissues to make a sling to try and stop the leakage. As you all are aware, I know maybe not those in Ghana, actually those in the UK, you've heard about all the issues around the synthetic sling. So these are obviously the slings that are made from like a nylon type of mesh, or what we call just meshes. Obviously, at the moment, are currently banned in the UK and some other countries. So native tissue sling, using your own tissue, your own body tissue to make the sling available. And it's probably one of the best operations amongst all the operations that can be done. And then we can do keyhole surgery, where we use stitches to try and leave the size of your pipeline, and attach it to the back of your pubic bone. And that is a fantastic operation also. So these operations have an improvement to a cure rate of about, 80 to 90%, so there are good treatments out there that can be used to help your stress incontinence. Next slide, please. And then when obviously we talk about the urge incontinence side of things, again, the general thing is that if you're having urge incontinence, you've got to avoid caffeine, and that's caffeine is in tea, it's in coffee, it's in your Coke, and so try and get decaffeinated form of those drinks. I see a lot of women, they come and say, I drink a lot of green tea. Green tea doesn't have caffeine in it. I'm drinking it to try and lose weight. But actually, green tea has lots and lots of caffeine in it. So you've got to be careful of that. Fizzy drinks are, not great for a bladder if you've got a problem with urinary incontinence. The carbonated irritates the bladder. So, it will be better to have still water than having a sparkling water. So try and avoid, fizzy drinks. Cut down on alcohol, because again, alcohol irritates the bladder. If you've got a normal bladder and you're drinking your alcohol, you're fine. But if you've got a problem like this, alcohol is not great for the bladder. So try and cut it down. Increasing how much water you drink is very important, because the more concentrated your urine, those chemicals become very irritating to the bladder. And therefore, it's very important that you increase your water intake, dilute your urine, and less irritating. Sometimes it's a bit of a, or the women think that, if I drink more, I'm going to leak more. And then I say, no, actually, it's the other way around. Try and drink more water. Cut down on all those coffee and the fizzy, drink more of water and get your urine more diluted, and you'll be fine. And then we've got stuff, what we call bladder retraining. So this is the point where you are having to, retrain your bladder. So when you've got that urge that you want to go, you try and distract yourself from thinking about it. Sometimes I tell women, if you have that desperation to get to the loo quickly, don't rush. It's important to just stop, and just squeeze your anus, because when you do that, that squeezing of your anus helps squeeze your pelvic floor, but also helps squeeze the area around your pipeline. And that stimulates some nerves, which goes back to relax that bladder muscle for you. And then the sensation, that desperate sensation to go, would go away. And then you can walk gently and get to the loo. Even if by the time you get there, it comes back, just stop, squeeze again, it will disappear, and then you can walk to the loo. Rushing will just make the situation worse. Some people will tap their toes, to try and distract themselves from, going. Again, that's a good strategy. Think about something else, and those are strategies that we talk about as bladder retraining. And when you see, your physiotherapist, they would go through all these kind of things with you to try and get you over it. Next slide, please. And then obviously there are other medical and surgical things that we can do. There are oral medications that we've got that are given to you to help the bladder muscles to relax. We've got something called anticholinergic drugs, and we've got another one called Merabegron. They will be your GP will give you, your doctor can give that to you to help the bladder muscles relax, and you can take that long term. There's no big issue. Yes, there are side effects to them, but it's a balance of the benefit you're getting from them compared to the side effect. And then Botox is fantastic. The Botox is not only for getting rid of those wrinkles or trying to relax those other muscles. We do inject Botox into the bladder muscles, and one injection can work for about 6 months to 2 years, and then you can have repeat injections. We do them just in the clinic, or if you're afraid, you can have in a short general anesthetic. It takes 5-10 minutes injection to do. The worst bit will be that you're not able to pee, but that can be managed. And then we've got special pacemakers, just like we've got pacemakers for the heart. We've got pacemaker for the bladder, and that we can put just underneath your buttocks, and that will last 5 years, and then we have to change the battery. And so these are things that are really, really good. And we say, don't suffer, come and see us or see your doctor and get some help. Next slide, please. So, my final slide is saying, please do not put up with urinary incontinence. Speak to your doctor and get some help. Those of you in Ghana, as part of the training that we've given to the team up there, we've got one top specialist in Korle Bu, trained from our program. One is at the Ho Regional Hospital, and another one is at the Okomfonoche Hospital. And then we've got Dr. Karim up in Tamale Teaching Hospital. So at least we've got 4, specialists in these kind of things. And we've got another 4 in the program who, in a couple of years' time, will be finishing. So please do not suffer. Speak to somebody and get some help. Thank you very much.
So thank you very much, Dr. Fiajo. We're going to have some adverts.
Enjoy some fabulous rewards. Get a cool £10 reward when you receive £100 or more from the UK. Tell your friends and family in the UK to send money to your mobile money wallet or bank account using Express Pay and get an extra £10. Terms and conditions apply.
So thank you so very much, Dr. Fiajo, for your presentation. So we will quickly be moving on to a final presentation by Dr. Dennis Danso. Dr. Danso is also quite international. As I said to you at the beginning, all the panelists have international experience. So Dr. Danso qualified from the University College London Medical School, and then completed all his postgraduate training in obstetrics and gynecology in the Oxford Deanery. She must be very clever then. He's truly international, having worked as a consultant for 15 years across 3 continents, so Europe, Australia, and of course, our motherland in Ghana. And he's had the opportunity to advise and treat and manage women with fibroids over many years, but especially when he was practicing in Ghana. He therefore brings a wealth of experience in that specific area in the management of fibroid, the subject that he is going to cover for today. So Dr. Danso, the floor is now yours.
Thanks very much, Dr. Mensah, for the glowing introduction. And also like to say thank you very much to Ghana Union for inviting me to come and talk about fibroids. We're going to have the slides projected for us. Also would like to thank the audience, obviously, for coming for this educational evening. So next slide, please. So what are we going to do today? Well, we're going to have a look at what are fibroids, who gets fibroids and why? What are the symptoms and signs that we need to look out for? What other conditions can mimic fibroids? Next slide. How do you make a diagnosis? How do you manage or treat fibroids? What are the barriers to accessing advice and treatment? And then, of course, we finish off with a summary and then any questions that you may have. So next slide, please. So what are fibroids? Well, fibroids, that term strikes a lot of fear in a lot of women. But fibroids are the most common benign tumor or swelling in the female. Benign smooth muscle tumor, benign meaning that it's not cancerous and is in the womb of the woman. It's rarely cancerous, probably less than 0.1%. But as I already mentioned, it becomes a source of anxiety when a woman is diagnosed with fibroid. It's always, woe is me. Am I somehow going to become infertile? Well, let's see what the next slide has to help us with. Next slide, please. So this is what we talk about. There's a little bit of a schematic diagram here, helping us to appreciate what we're talking about. So we've got the two pale ovaries showing on the stalk, and then the darker area is the muscle of your womb. And then we've got those rounded figures and then the muscle. And that's how fibroids can look like. Next slide, please. So this is real fibroid. This is quite a sizable one. We're probably looking at, there's two fibroids there, probably looking at in terms of pregnancy weeks, probably about 24 to 26 weeks size of pregnancy fibroid. So that's how big these fibroids are, equivalent to 24 to 26 weeks of a pregnancy. Next slide, please. And there's another depiction helping us to see how the fibroids can look in a specimen of the womb. Next slide, please. So who gets fibroids and why? Well, 20 to 40% of women in the reproductive age group would have fibroids. So it's quite common. It's commonest in Black women. It's been said that every other Black woman you see would have fibroids of some number and shape and actually site. So it's a pretty common condition. We do know that women who haven't had children or haven't had kids represent a risk group where there's a higher chance of developing fibroids. Obviously, if you have more children, then there's less of that risk. Obesity has been also shown to be a risk factor. Strong family history too can be a risk factor. So if your grandmother's had it, your sister's had it, then you have a higher chance of also developing fibroids. Those who have early onset periods also are in the risk group of developing fibroids. No doubt there is a genetic basis. This is not to say that you inherit it per se, but genetic basis in the sense that when fibroids are analyzed in the lab under the microscope and sort of molecular studies are done and genetic studies are done on it, there are mutations or chromosome abnormalities that are associated with some fibroids, not all. Next slide, please. What are the symptoms then and signs of fibroids? Well, in over 50% of women with fibroids, there are no symptoms. There's nothing at all to show for it. And in the rest, the presentation, the commonest would be abnormal uterine bleeding. And that can be either they present with heavy, painful periods, or a lot of pain just before their periods. Some can also present with bleeding in between the periods. And occasionally you might have women who present with discharge because of a fibroid that is perhaps sitting very close to the neck of the womb. Others also would present with abdominal swelling. And of course, because of the size of the fibroid and the position, if it's a big one, then the woman would experience pelvic pressure and pain. As Dr. Fiaggio had already indicated in his fine talk there, when there is pressure from fibroids, because you've got a bladder close to the womb, then what you're going to find is that it can increase the frequency of having to go to the toilet to do a wee. And occasionally women can go into urinary retention where they can't pee because the fibroid has caused obstruction, but that is not a common presentation. And there's the other side related to the fact that the intestines or the bowel can be close, the large bowels can be close to the womb with fibroids, and occasionally you might get constipation as a way a woman presents. Next slide, please. And this is the dreaded area, reproductive dysfunction, because when, as we said earlier, once a woman knows they've got fibroids, the sort of the instinctive reaction is, oh, woe is me, you know, somehow I'm not going to fall pregnant. That is not true. If anything is to be taken away from this conversation this evening, it is this, that the sheer presence of fibroids does not mean that a woman will be infertile. In fact, when we look at the infertile population, those who come to clinic because of infertility, fibroids are present in only 5 to 10% of such women. So that's important information. And when it comes to women who you can put fibroids down as perhaps the sole cause of their infertility, we're probably looking at a percentage between 1 to 2.5%. So really, fibroids per se are not the cause of infertility. So in fact, if you have fibroids and you think there are, or you might have infertility problems, I think it's really worth investigating the man and the woman, because the problem may not necessarily be coming from the woman at all. So that's an important take-home message. Next slide, please. So what other conditions then can mimic fibroids? Well, pregnancy, obviously, because if you have a tummy that is distended by pregnancy, then that can mimic fibroids. Ovarian cysts can also do the same. Ovarian masses of the ovary and the tube together can also mimic fibroids. And adenomyosis, endometriosis is a condition that it's quite common. They sometimes can also mimic fibroids. Their presentation can also be very similar to fibroids in some context. And of course, ectopic pregnancy situated outside the confines of the womb can also present or mimic fibroids because of the acute pain presentation that the woman may come in with. Fibroids can also cause acute pain in some women, particularly when they're breaking down. Next slide, please. So how do you make the diagnosis then of fibroids? Well, it all starts with the story of the woman, what the lady tells you. So we already alluded to the fact that a lady may come complaining about heavy, painful periods, and the lead up to her periods, she may be complaining of a lot of pain, or she might frankly come and present to you with abdominal swelling, which will be the first presentation or clue to the fact that she might have fibroids. Of course, if you place a hand on the woman's belly and it's a big fibroid, then you will be able to make that impression. A vaginal examination sometimes may have to be done to draw that conclusion that we may be looking at fibroids. But of course, we need to back up the clinical impression that we have with imaging, such as a pelvic ultrasound scan. And I'm sure most of us are familiar with that. A pelvic ultrasound scan is the gold standard in actually picking up fibroids. It can help one to differentiate between fibroids, ovarian cysts, pregnancy, and so on. So it's quite a key way to really find out whether a woman has fibroid. But of course, when the confirmation is made that a lady has fibroids through a pelvic ultrasound scan, and there's a need to perhaps look at mapping out a treatment schedule, then of course an MRI scan can give better characterization and clarification of what one may be looking at. Next slide, please. So this is just to help some of us to see what we're talking about when we mention ultrasound scan. On the left, we have an ultrasound scan machine. It's not a painful procedure. It just involves having to smear a bit of gel on the woman's belly, and then a probe is applied onto the belly, which is non-painful, and the pictures just come on the monitor there, and you can quickly make a diagnosis. It only takes about just a few minutes to do that. Then, of course, on the right, with a big gadgetry there, that is the MRI machine that is used on the right. It involves having to be placed into almost like a tunnel. There's a lot of noise that goes on in there, but there's nothing harmful. It just helps us to see exactly what's going on. Next slide, please. So how do you manage or treat fibroids? Well, the truth of the matter is that for the vast majority of women, if they don't have symptoms, then there's nothing to be done. You will have to pursue an approach of masterful inaction, just observing. It may be that you might have to monitor the fibroids by maybe performing regular scans. Regularity depends on what you're looking at. Sometimes yearly or 2 yearly, depending on what's going on. But of course, if the woman has symptoms such as heavy, painful periods, then medical treatment can be brought to bear. Anything from taking non-hormonal medications to using hormonal medications, including the contraceptive pill, pain killers to control pain, all the way to injections that are used under the skin to shrink fibroids. Those are all ways of helping. But with respect to injections, sometimes it's just a temporary measure or a temporizing measure that leads to perhaps a more definitive treatment. So there's a lot that can be done if a woman has symptoms from fibroids. But of course, there comes a time where medical therapy is not the solution, or it needs something else doing. And that would be in the form of surgery. And the surgery would be either removing the fibroids, shelling them out under anesthesia, usually a general or a spinal anesthesia, where the woman is awake, or a hysterectomy as a last resort. So that is the surgical approach that can be taken to really get to the bottom of the problem, removing the fibroids away completely. Just to mention that with the medical treatments, you're not taking the fibroids away, but you're managing the symptoms that come along with the presence of fibroids. And of course, there is the embolization procedure in selected women, which involves having to block the blood supply to the fibroids, and thus attain a shrinkage of the fibroid and improvement of symptoms. You're probably looking at about a 60 to sort of 80% success rate with that, but there's a clear selection criteria that has to be used in this context. Next slide, please. So, as our theme has to do with barriers, I just like to highlight some of the things that our dear Dr. Pepra mentioned in the opening. I just wanted to mention about, first of all, the lack of health education. So, for example, the conversation we just had now, hopefully, would help women appreciate that having fibroids is not a death sentence. It doesn't mean you can't fall pregnant. And therefore, the anxiety that comes along with that, and therefore a rush, perhaps, to alternative traditional medicine can be reduced. Now, when I mention lack of health education in conjunction with alternative traditional medicine, it's not to necessarily trample down on the value of traditional medicine, but it's fair to say that all too often, these so-called alternatives saturate the radio waves, particularly in Ghana, where, in fact, misinformation seems to be sometimes the order of the day. And unfortunately, that strikes a lot of fear in our women, and therefore end up with our women accessing care in the wrong place. So that in itself becomes a problem. And of course, it's been mentioned by the religious beliefs, how sometimes clearly a fibroid needs attention, but then women might believe perhaps that prayers might do it, or perhaps they might believe that somebody is perhaps responsible for why they've got fibroids and so on. Those things don't help women in trying to access the right care and in the right place. And of course, in our setting here in the UK, maybe other barriers such as immigration issues, other cultural issues that may play a part here. Next slide, please. So what are we saying then? Well, what we're saying is that fibroids are common. For the most part, a watch and wait approach is okay. There's nothing wrong with that. You don't have to rush off to surgery. I've seen too many women, very young women, rushing off to surgery, and then not too long after that, maybe 5-10 years down the line, they come back again with fibroids, still haven't had kids, and then that becomes a problem. Because the more surgeries you do, the more difficult it could be when it comes to falling pregnant. The other point highlight here in summary is that treatment is available. Don't suffer in silence. And the last point, but not the least, is that please consult a trained medical doctor, ideally a gynecologist, somebody who spent time managing women with this condition, so that not only do you necessarily have to have treatment, but at least having a balanced consultation and indeed counseling around the subject. Next slide, please. So this is where we'll draw the curtain on my presentation. Any questions?
Enjoy some fabulous rewards. Get a cool £10 reward when you receive £100 or more from the UK. Tell your friends and family in the UK to send money to your mobile money wallet or bank account using Express Pay and get an extra £10. Terms and conditions apply.
Okay, so we've had the opportunity to listen to all three speakers, and they've covered different subject matter in relation to women and some of the barriers too. But one of the biggest advantages that somebody who is chairing the meeting has is that he or she gets a chance to ask questions first. So that's exactly what I'm going to do, because I'm not going to let that opportunity pass, because I might not get it again. So my first question really goes to Theodora. Dr. Theodora Pepra. I certainly identify with some of the issues that you raised in terms of some of the religious barriers, because I've seen that when I've done courses in maternal, the obstetric emergency training programs in Ghana. In fact, in the Western region, I was there training when a woman died because the baby was lying across the womb. The waters have gone. There's no chance of that woman having the baby naturally, but a pastor had advised that the woman should not have surgery. And the woman died and lost the baby as well. Now, so on that very, very basis, what do you think we can do as far as the religious leaders and the churches are? Because it seems to me that they have a major, major role to play in various aspects of health. What will you say to that?
I think it's an excellent question, and it's our biggest challenge. And I think if history has taught us anything, simply telling people that what they're saying is just not the case and is dangerous doesn't seem to be enough. Women seem to be ready to risk their lives and risk the lives of their children and unborn children because a pastor says so. And then when the person dies or the child dies, it was God's wish. It's a real challenge. Now, as I've said, I think we have to realize, when we're kind of a bit beaten, and if we can't beat them, let's pull them in. This is where the only way I see is bring them in, trying our best to get them on side and educate them, and then let them go and tell the others, because I think we're fighting a losing battle, simply telling women that this is not the case, because there's just this inherent, almost sometimes irrational belief. And I think, colleagues spoke about fibroids, and sometimes it's not just an education thing. I've seen nurses who have had small fibroids, maybe 20-week size, advised to have surgery done, disappear, come back with an HB of 4. This is in the UK, a Ghanaian nurse in the UK. And then by the time she came back 2 years later, it was nearly 36-week size uterus. So I said, I'm sure you were advised to do something 2 years ago. She said, oh yes, but I went to pray about it. So she said, are they not gone? I said, no, they're still here. And I said, your prayer brought you back to the hospital for me to see you. That's what the prayer did. But it's a real problem. And I, except for getting the pastors or their wives on side, I don't really see a way out of it, and I don't know if anyone else has any other solutions.
Thank you, Theodora, and maybe some other questions and comments will come through. So, right, so I have another question. Well, I have a question for each of the presenters. So I'll go to Paul. Paul, I had the experience of visiting a Ghanaian couple that I know very well, whose wife had this incontinence issue after she had a baby, and was so distressed by it that she really wouldn't go out. And of course, the depression set in, and she was at home. She was comfort eating. Unfortunately, put on a lot of weight, which obviously didn't help with the incontinence issue, and also raised the issue of very heavy periods, because she's not put on so much weight, and therefore had the issue of heavy periods as well in there. So now I'm going to go very controversial. So, should all women have their babies by cesarean section to stop all this issue of continence and incontinence?
Yeah, it's a very, very good question, and like you said, very controversial. Obviously, there's a long and short answer to this. And so in terms of the research, for you to be able to prevent one person from getting urinary incontinence, you need to do 10 cesarean sections. So there are 9 other women who would have had a cesarean section and they were never going to develop urinary incontinence. So you're basically doing unnecessarily 9 cesarean sections. And obviously from the medical side of things, the view is that, that is too many unnecessary cesarean sections that you are undertaking. Now, as during my talk, one of the things I mentioned is that being pregnant is bad enough, so, the journey has started. They meet the time you decided to get pregnant with all that pressure on the pelvic floor. But also, the next thing you think about is that, menopause is still there as a risk factor. So there are many other things that, can lead to the problem, and trying to avoid, trying to hide from one of them is not necessarily going to prevent that. And overall, like I said, the biggest risk factor in all this is the age at which you're having your very first baby. The earlier, the better. So you've got to be having your first baby before the age of 25. Otherwise, think about booking an appointment to see me.
Okay, thank you very much. Yeah, just I was deliberately controversial about that, so that's great. So I have a final question for Dennis. But before I ask the question, just a little bit of I had managed somebody who had heavy periods. Fibroids were not too big. They were not in the womb itself, and so we did ablation for her. And of course, she didn't have any periods at all. And the shock of it all was that she came back to the clinic asking if they could do anything to let her have at least some period. The whole idea that there was no period at all was not very satisfying to her, and she's finished her family. So I just wonder whether that is an issue with our Ghanaian community who don't want to go for treatment. But my question to you, Dennis, is this, that should women have fibroids removed before they embark on a pregnancy?
That's an excellent question. I would say yes and no. Yes and no. No, in the sense that for the majority, it's okay. They can still fall pregnant, as we said before, because having fibroids per se, the sheer presence does not mean that you can't fall pregnant. But when it comes to very big fibroids, before one falls pregnant, there's always that concern that if the fibroid undergoes the process of degeneration and the potential problems it might cause with delivery, then there could be a case made. It has to be a case-by-case basis made for some women with big fibroids to consider removing them before falling pregnant. But in the main, I think you can leave them alone.
Thank you very much. So I've exercised my my privileges. Now is open to the audience. So Emmanuel, are you going to ask the questions from the chat?
Yes.
Yeah.
It's so much interesting how much knowledge this expert has brought. I just don't even know where to start. But I'm going to allow those who have raised their hands to go first, so that at least we can hear directly from the audience. If I can call Elizabeth Amoa, please. Elizabeth, your hand is up. Thank you.
Yes. Good evening, and thank you for this insightful talk. And it is very dear to my heart. Myself, I am a patient with fibroids. I do have multiple fibroids. There are some kind of questions that I have. I remember when the doctor that spoke about remedies, natural remedies. I do understand in Ghana, a lot of people listen to, I would say, fake, tapes or fake advertisement in regarding to herbal or natural remedies. Me, I use natural remedies to kind of manage my fibroids. It's been over 12 years, I would say at least, and my fibroids hasn't grown. I would say 12, I would say 11 years. It hasn't grown more than 3 centimeters. Obviously, I eat the right food. I don't eat like red meats and all that kind of thing. So it's management aspect. So why don't we say that it's not not every herbal remedy is not good, but then there are reliable ones that people can use? That's one of my questions. And another question too is regarding the infertility aspect. He mentioned it's 1 or 2%, which I think is not true. The reason being, we know statistically it's at least 10% of infertile women, have fibroids, I would say. And even me, when I was diagnosed fibroids, I was told I could never have a child because of where the fibroids were located. Obviously, I fell pregnant, which does happen sometimes. There are also women with fibroids that have had recurrent miscarriages and cannot carry children to full term. So where did that statistic come from? And why? And personally, I know a lot of women with fibroids that cannot conceive, and it's solely because it's fibroids. And even some of the medical professionals do tell them they cannot conceive because of the fibroids. So I just need a bit justifications on these two.
So
thank you very much. So any of the panelists can help with this question, if please.
Yes, just to pick up on the first point about the herbal alternative medicine, as I said in my presentation, it's not as if one is against them, but the truth of the matter is that when you have, like in your case, for example, having fibroids doesn't necessarily mean that they will keep growing and growing and growing and growing. No, there are some women, we don't fully understand all of it, who have fibroids and the fibroids just remain where they are. Particularly ones who've had kids, the fibroids don't get opportunity to keep growing. So a woman who may have multiple fibroids and the mere fact that the fibroid hasn't gotten bigger and bigger and bigger, and they're taking alternative medicine, it's difficult to be confident and say there's alternative medicine that stopped that from happening, because it could even happen without having to take any herbal medicines. So that's the one thing. But if a woman feels that herbal medicine is helping them, I wouldn't necessarily say they shouldn't pursue that. But you must remember that there's a lot of, if you like, fake persons around. Sometimes they sell women, as you probably would know, steroids for medicines, and in the end, people come to harm. And as we speak, I have a friend who's had exactly that same problem, where she's been sold steroids for many years, actually. And now she's almost a cripple because all her bones are thinned out. So it's just a cautionary note. But then having said that, with conventional medicine, the evidence is there. We can provide the goods as well. Show the evidence, whereas a lot of these alternative medicines, the evidence cannot be provided. It's always anecdotal, I had it and this happened, rather than say, this number of women came together, they were given this herbal medication, and this is the result. We don't have that. And so that makes it difficult to hang a lot on that. With respect to the question of, what was the second? Just remind me of the second one again, please.
I think it was to do with the statistics.
Yes.
About the stats, yeah.
Yes, about the stats.
Yeah, this about the stats. No, it's not 10%. It's like I said earlier, when a woman cannot fall pregnant, there are all sorts of reasons, things that can be related to her not falling pregnant. So anything from egg production, the quality of egg, to sperm production, the quality of sperm and its motility, to the tube environment and the functionality of the tube itself, all the way down to the womb itself, where implantation happens. So there's a lot of processes involved. So if a woman has fibroids and they can't fall pregnant, you cannot categorically say that is the source of the problem. So that's why I said that both the man and the woman will need to be investigated thoroughly. But the fact of the matter is that for fibroids to be the sole cause of infertility, that's really about 1 to 2.5%. And it's usually when the fibroids are impinging or blocking the fallopian tube, but not, and you can see that when you've really investigated such women.
Okay, thank you very much, Dr. Danso. And I want to ask one question before I go back to Sheila, whose hand is up. There's a question: is why do some women have periods not inconsistently? So you have 1 month, 2 months, and then it stops for another 3, 4 months, and then it starts again. How do we explain something of that scenario? If any of you can take it, please, we want to try and understand some of these things, if it's something that you want to address.
Well, I think basically it needs to be investigated. She needs to see a healthcare professional, have a proper history taken, because the advice and investigation outcome depend on the age. There's several factors we would look at. So if you're not having regular periods and you're concerned, there may be a reason why they're coming like 2 in a month, or they don't come for 2 months. There's so many factors that are involved. Usually it might be something hormonal, but if they're coming more frequently, actually that might be something more sinister. So the bottom line is, it's not a question we can answer without somebody seeing you and taking a detailed history from you, and what medications you're on. These can all have an effect as well.
Okay. So traditionally, some people, obviously in the more traditional context, there is this idea or perception that fibroid can be taken out during delivery. So don't bother doing anything. Or when you get pregnant and you're about to have the baby, it can all be moved out. Is that also something somebody you can address? I mean, does it happen sometimes, or is just a no? The two don't work.
Am I able to take that?
Yes, please.
Yes. The traditional received wisdom and teaching is that you don't touch fibroids during pregnancy, particularly at cesarean section. And the wisdom there is that normally they're very vascular, and there's the potential for bleeding. So if you have a relatively straightforward cesarean section, that can be converted into a potentially difficult experience with bleeding, hemorrhage, anemia, and the use of blood products and so on. So that has been the received wisdom. But the truth of the matter is that after having spent some time in Ghana myself, there's an increasing trend now in Ghana, at least I know, where we're beginning to offer women removal of fibroids at the cesarean section. My only concern with that approach is that yes, we need to select women carefully, because I don't think there's clear selection of women. And secondly, there could be sort of monetary incentives as well, because obviously a cesarean section is more expensive compared with a vaginal birth. And unfortunately, there appears to be that sort of tilting toward that direction. Let's do a cesarean, get it all out. So it needs to be looked at very carefully. Yes, it can be done in selected patients, and it can be very successful in my experience. Yeah.
Thank you so much. I'll go to Sheila, please. There's someone has called Sheila up on the screen.
Yeah, hi, thank you. So can you talk a little bit about what it means when a fibroid is calcifying? So the calcification of a fibroid, is that something to be concerned about, and what can be done? And then I've just got a couple of comments, if that's okay, after that question's answered, please.
Dr. Pepper, do you want to take that? Or?
Thank you. Well, I mean, I defer to your fibroid wisdom, but from my understanding, if it's calcified, you're less likely to have a problem with it being a malignant one. So in some ways, it's somewhat reassuring if you see calcification in a fibroid and not something to worry about.
Yeah, I definitely concur with that.
Yeah.
And you tend to find that a lot in older women as well.
Okay.
Yeah, and then a couple of comments, like I didn't know that it's preferable for women to have children before the age of 25. And that's that's actually very upsetting to hear that. I'm kind of, at least a decade out, sorry, not 10 decades, 1 decade out. But so that's really upsetting. And I think another issue just to raise, to put it out there, it's not really a comment, but just the idea, I know so many women, Black women, who are committed Christians, and the culture is to wait for your husband. And I know too many women in their 40s and 50s and 60s that are just, alone and have just waited. And it's difficult because the pressure is, wait for somebody, you definitely want someone who shares your faith and stuff. But I think there's actually an issue that I think there's something wrong, and that we need to talk about there, because there are too many, I don't know the stats, but I think that there are too many older women who have been very timid or passive in terms of getting married, or kind of passing on people because they're not quite Christian enough or whatever the community says, and I think that's a massive issue because it's affecting people's lives in a huge way. So just sort of flagging that. I don't know that anyone's can comment on that, but it's just something that I think is, it's something there that we don't really talk about.
Thank you very much. Yeah. Doctor, please go ahead, Dr. Paul.
I don't, obviously we're talking, when we talk about the age side of things, we're talking about obviously trying to prevent yourself from getting the problem. You can look at it two ways, that, you may be designed to have babies. So even, get lucky that having your first baby, at 35, 40, and you still be okay. The other side of it that I would say, is also quite reassuring is that we've got very good treatment if you end up with problem of incontinence that we've just talked about, and they are very, very successful treatment. So, even if you go pear-shaped, we'll still be able to help people.
Thank you. That's quite reassuring to know. Dr. Mepra, if you want to add to that.
Yeah, well, I think I really wouldn't want a take-home message from women that they have to really push and have their baby by the age of 25, or they're going to be incontinent. And that's the kind of message I'm hearing. And if I comment from a friend who was listening and said, now the women will be running to church to look for a husband after you know, because this is what and you know, if my experience, I had my first child at 30. And in the UK in the mid 90s. And at that time, I was described as an elderly mother at the age of 30. And, you know, and I thought we've moved beyond that, but no, you seem to be taking us back there, where that even beyond 25, we are kind of elderly. And I think please reassure women that they don't, because, you know, we're talking about women being empowered, career women. You know, 25 is, you want to have a baby by 25, you've not even finished your university or your master's or what you want to do. So please don't give us some hope for
Yes.
those.
I was thinking along the lines of the fact. That you said this is kind of the ideal age to have. It doesn't mean that you must have your baby before.
Yes,
25.
but you being the expert, people will listen to that and hear that I need to have a baby by 25, otherwise I'm going to be incontinent.
Yeah.
I'm absolutely serious about that. I know what you're saying, and I can, you know, put it into the right box, but I think that what I'm hearing is have a baby by 25. Otherwise, well, you may be lucky, your pelvis might be okay. You know, I just think it's going to make the work harder for, you know, and men may be pushing their wives to have a baby by 25 as well, because they don't want I don't want you as an incontinent wife later. No, but seriously, these are serious messages that we say it, and I understand the medical context, but I'm also thinking people listening, how that might be perceived.
I think that I agree with you. You know, when you come to information sharing these days, obviously, you know all the stuff that is going on up here now in terms of, you know, giving or empowering women means that you give them information so that they can make their own decision. So what we are saying is that ideally that's what should happen. But even if that doesn't happen, when you do have a problem, there are very good treatments. So at the end of the day, the woman will have to balance, okay, you know, I've got to have to wait for the right person. But if even I have a problem, they say they can fix it. Whilst, you know, I cannot tell the same thing to that woman who is come to see me, you know, who has got some issue with her bowel because she had an anal sphincter injury. And okay, yes, we fixed it. But when I saw her back in her next pregnancy, there seems to be issues with her bowel. And I would tell that woman that 100%, there's no way you should be having a vaginal delivery. You need to have a cesarean section, because the information to that woman is to say, I'm sorry, whilst I can fix urinary incontinence, fixing bowel incontinence is incredibly difficult and very unsuccessful. So incontinence, if a woman comes to see me and said, oh, I've got urinary incontinence and I'm going to have this baby, do you think I should have a cesarean section? I said, no, go and have another vaginal delivery. Come back. If there's a problem, we'll fix it, because we've got very good treatment. But I won't say that for the same thing for bowel.
Okay. All right. Thank you very much. I think we've got the message. The message is that where possible, if possible, but if it's not, there is still room that can be helped to get it done. I don't think it's going to be translated in that. I think that was the key message here.
Correct.
Obviously, life is not like the ideal life would have been nice, but it's not always simple to to go through the ideal life in this world. So I think the message is quite clear. We're going to take a second break so that the expert can have a cup of water to drink quickly, and then I have a few questions that we'll go through, and then hopefully that should take us the next 15 minutes to round up. We've got about 5 more questions to go through, and then I'll go through some chat questions, please. So a few seconds break, and then we will come back to the questions that we have.
Enjoy some fabulous rewards. Get a cool £10 reward when you receive £100 or more from the UK. Tell your friends and family in the UK to send money to your mobile money wallet or bank account using Express Pay and get an extra £10. Terms and conditions apply.
Welcome back, and thank you very much for being with us. This program, again, is being put together with the help of the Ghana Nurses Association UK, the Western Region Association of Nurses UK, the Nightingale Nurses Association UK, and of course, Ghana Union. It is supported by the Ghana High Commission, Omega Live TV, and proudly sponsored by Express Pay. Your money in safe hands, and we please ask you to patronize them where possible, and hopefully your recipient will get a cool £10 when you send over £100. I'm going to tell you about the next program, and before we go to the final few questions on screen. Next 2 weeks, on the 23rd of July, we will be taking it slightly into the community much more. We will have the Honorable Minister of Information from Ghana joining us on this question time forum. The minister will address very key issues within the community that we have been passionate about. A lot of us keep ringing and asking, oh, Mr. Kwesi, what are we doing about this? What are we doing about that? So please, if you can share with your colleagues, next week, we will be looking at issues such as sorry, bear with me, I'm trying to get my screen to tell you the issues that the minister will be addressing. The minister may address issues around free SHS, the rationale behind the double track system. The minister will also take us the strategy behind Galamsey and restoring Ghana's water bodies and land bodies. We may be able to talk about government policy on banning excavators instead of returning it for state use. We will also look at strategies on curbing armed robbery, insecurity, increased rate of crime in Ghana. We will also go through government response to the perceived culture of silence that people are talking about all over in social media. And we will look at the government response to the COVID-19 pandemic and others that you will be passionate to want to talk about. So please, on the 23rd of July, we will have Honorable Kojo Opon Nkrumah appearing on this forum, and I encourage as many of you to share the knowledge around your community and around your friends so that you can have your questions answered. He is the spokesperson for the government. He's the Minister of Information. He's the one right person we can ever get to hold a town hall meeting with us. And then further to that, we will revert to other health and other community-related topics. Thank you very much. I'll go back to the few questions that I have with me. There's a question about Dr. Pepra or any of our experts tonight, if you can help us to address this. Somebody wants to know if does a woman need to consider specific gynecological checks when considering getting pregnant? Is there any specific checks that you would advise any woman looking to want to become a family, that they need to undertake certain checks before they even plan a family life? And if so, how regular that check should be taken? Because I know in UK here, at some point in your age, your doctor will just call you and go for MOT, whether you like it or not. And in some countries, obviously, the facility is not there. But for instance, I was called to go to my GP, even though I didn't have any reason to go. And then he did whatever he had to do, and that's it, I'm done with him. But we just want to know if, when it comes to women, specific checks that are there that can be done when they are considering becoming a mother.
Who's going first? Maybe
any one of you can take the question.
Okay. I believe it's actually a good thing if they see their doctor or their attend their reproductive health center and have somebody just go through with you. What are your periods like? And identify, are you up to date with your pap smear? Because what you don't want is have an abnormal pap smear during your pregnancy, or heaven forbid, cervical cancer during the pregnancy. Have they had certain vaccinations like rubella? Are they up to date with those? These are vaccinations that it's better to give when they're not pregnant. So all those things you can go through, and sometimes you identify things like diabetes and blood pressure, things that could become a problem during the pregnancy, so they address those beforehand. And very important, you can check that they're taking the right medication, like folic acid should be taken by anyone trying to get pregnant, because the best effect of folic acid is from the time of fertilization up until 8 weeks gestation. So even by the time you realize you're pregnant and you've missed a period, we've kind of already missed 2 crucial weeks of the development of the spinal cord of the baby. So folic acid is very important. But if you go and see somebody, they can advise you on all of these, and I think importantly check, because diabetes and blood pressure are big problems for our communities, and so it's well worth knowing whether they are factors at the beginning and addressing them before she even gets pregnant, and actually correcting those may actually help her have a smoother path to getting pregnant, and that way she'll be pregnant before she's 25.
Well, I think the other issue, and I used to run, if you like, a pre-pregnancy counseling clinic, and that was basically for women who had pre-existing conditions, like women who had hypertension, women who had thyroid disease, women who had diabetes, and so forth and so on. But for the ordinary punter, that probably is not necessary, apart from what Theodora has said. So these were women who had pre-existing conditions. Diabetes can be affected by the pregnancy, and the pregnancy can affect diabetes. If you're hypertensive, it depends on what medications you are taking, because some medications are very good for your pregnancy, for your hypertension, but it will be a disaster if you were taking them in the course of pregnancy. And of course, with thyroid disease and so on, again, what are you taking, and can we get it under control before you get pregnant? So the question really focuses on those that are known to have some pre-existing condition. But there are some general things, if you're overweight, you'll be advised to reduce your weight before you get pregnant, because then you have a risk of diabetes occurring during the pregnancy, which you didn't have before. So we need to separate those. So there are general things that your health professional, even the nurse or midwife or so, can advise you on before you get pregnant. But if you have a pre-existing condition, it is imperative that you get seen, get it nicely controlled before you get pregnant. Otherwise, you might find that you get pregnant and it's too late then to change. As Theodora said, by the time you actually know you are pregnant, or up to about 8 weeks into the pregnancy, the baby is already forming, and the harm would have been done already. And so the message to our community is that if you have any of these conditions and you're pregnant, it's imperative that you see a healthcare professional for advice. Okay.
Thank you very much. I'm going to ask this question from the chat room. Does fibroid cause early menopause? And can a woman get pregnant while in early menopause?
Yes, the first question about does fibroid cause early menopause, the answer is no.
Right.
So that's very simple. The other bit, can you fall pregnant during or perimenopause? The answer is yes. Because even though your ovulation is a bit infrequent, under the right circumstances, if there's a sperm around and the conditions are good, then you could fall pregnant. So we always say to women who are perimenopausal to use a proper form of contraception, lest they fall pregnant unexpectedly. You can only stop those things if you've gone a whole year at the right age without a period.
Right. Okay. Thank you very much. There's someone's hands up. Soronia Hajara Shadow. Please ask your question, please. Thank you. Hajra.
You are very excellent program for women. Well done, Chairman. I'm the treasurer of Ghana Union, and somebody has asked me to ask this question. At what size of the fibroid do you really need a cesarean? I mean, to have an operation? Dr. Danso, please.
Yeah, please, is this with reference to removing fibroids at cesarean?
No, removing the fibroid with operation instead of managing the treatment, having the
right.
The procedure for it. At what size? When? How big should it be that you should agree to that?
It's a bit more nuanced than that. There's no simple yes or no. I think the person needs to be assessed quite carefully before a decision is made to operate. So I wouldn't say if it's 5 centimeters operate or if it's 7 operate. No, it all depends on the circumstances. So for such a person, I recommend that they speak to a trained doctor in the area and get the right advice.
Right. Thank you. Thank you very, very much. Can you okay. So somebody want to know, I think that will be our final question. Somebody want to know, what are some of the gynecological problems can lead to cancer? Can be clearly lead you to cancer? Or I don't know what type of cancer they are referring to, apart from some of the ones that I mean, maybe the person came late and they couldn't hear much of what some of you may have said. But if you can give some few other irregularities within that aspect of human body or women aspect of life that can become a trigger for cancer.
I don't know if I should take this. In terms of interesting, what leads you to cancer is a funny way around of saying it. But certainly if women have, I think abnormal menstrual bleeding is a key thing, or abnormal discharge is a key thing that needs to be investigated and not ignored, and certainly not treated by putting ginger or anything up there. It needs to be addressed properly. And I think people tend to think, oh, it's going to sort itself out soon, it'll sort itself out. Don't leave it too long. If 2-3 months you're having this regular bleeding, particularly if you're over the age of, I would say 35 to 40, please get it addressed and seen to. Talking about in terms of not even reaching cancer, this is where you avail yourself of the cervical screening so we can pick it up at a pre-cancer level. And it's advisable for any woman who's ever been sexually active even once. It's not limited to promiscuous women or anything like that. It's important that they go for screening, because from 0 to cancer is 10 years. So we have at least 10 years in which to pick this up and then treat it with a simple treatment that will allow them to go on and continue having children. If you leave it until such time as it becomes a cancer, then the treatment is more aggressive, and even that rather will make you infertile. Now, I would just touch on something that, I know in Ghana, some doctors have told me that before they had training from me, their understanding was even if somebody has pre-cancer of the cervix, so they don't have cancer, but they pick up this an abnormal smear, the treatment they've been giving them is a hysterectomy. Now, things like this will obviously deter women from going even for the pap smear, because they say, go for the pap smear. If it's positive, they're going to take your uterus out. Now, this may sound ludicrous, but it happens. And I've had doctors who said, we didn't know any better. So one of the things I'm doing is traveling around the country, training them about how to do these small diathermy treatments so that we're not actually, and so encourage women to do the right thing. But women should please attend if they have a discharge or something abnormal. And also the breast side of things, don't be embarrassed. Please find a way, go with a friend, seek some help, and the help is out there. So if anything isn't quite right, but get to know your own body. That's the take-home message.
Thank you. Thank you so much, Dr. Pupra. I was going to end, but there's this question I think is quite important. Can a woman taking apixaban, I don't know how if I mention it, for blood clot try to be pregnant? Can a woman taking apixaban, I don't know, for blood clot try to be pregnant, or can I'm sure you get the message.
Yeah, we get a message.
Dennis will take it,
Yes, the answer is yes, they can fall pregnant, but they will need to, again, as Dr. Mensah said, if you have any pre-existing medical condition, please go and speak to your doctor so that you can have a proper assessment, and then you'll be fine.
Right. Thank you so much. I think that's all that time will allow us to be here tonight. What can I say, Dr. Paul Mensah, my fellow Santa Crocian, thank you so much. With a huge depth of gratitude.
There are three of us here now.
Oh, is it?
Stop this old boyism and old guys.
With a huge depth of gratitude for bringing this excellent panel. I didn't do anything to get you together. You just went with it, and we all went back and forth. Dr. Dennis Danso, thank you so much. The knowledge, the experience, and everything that all of you have brought tonight is more than we can ever ask for. Dr. Paul Fiaggio, I'm very grateful. You've given us more than the community need. I hope we can continue to count on you. What I may ask the four of you to find is that you can find us equivalent, excellent panel that will help us treat issues about men. And I think I will follow that on our platform. Because otherwise we may be seen as we've talked about the women. What about us? So I think we can deal with that. Dr. Theodora, I'm very grateful. You are a very key person that I've come to love and respect. Thank you very much for your knowledge and experience. And on behalf of the Ghana Nurses Association UK, on behalf of Western Region Nurses Association, and on behalf of Nightingale Nurses Group and Ghana Union, I want to thank all of you. Thank you all, the audience, for being with us, and continue to be safe and stay well. Have a good night. Thank you very much.
Enjoy some fabulous rewards. Get a cool £10 reward when you receive £100 or more from the UK. Tell your friends and family in the UK to send money to your mobile money wallet or bank account using Express Pay and get an extra £10. Terms and conditions apply.